Today we're going to discuss maintenance programs. Maintenance programs are an integral component to therapy. So we decided to host this presentation because maintenance programs are also a key component to Legacy's advanced approval process for exceeding the $3,700 PT and ST combined threshold and the $3,700 OT threshold. Therefore, it's very important that everybody understand what a maintenance program is and how to create an effective maintenance program. Basically, Medicare will either pay for continued skilled services if the client is making measurable and functional progress. However, in the case that they're not progressing, the client can still qualify for services if they need therapy. Medicare will reimburse therapists to use our skilled knowledge to create a maintenance program and then train the patient or caregivers to implement the program. Medicare will not pay for therapists to implement a maintenance program on a day-to-day basis, so that's very important to keep in mind. One more thing that I want to address before we get started, I want to briefly discuss the difference between a maintenance program and a restorative nursing program. A restorative nursing program is typically seen in skilled nursing facilities, and it's supposed to be developed by nursing in order to assist clients in restoring strength and function after an injury or hospitalization. And then after a period of time, if that strength or function isn't restored, then nursing would refer that client to therapy. But sometimes what we see in nursing homes is that therapists create maintenance programs which are then implemented by the restorative nursing aides. So this then muddles the waters regarding the differences between the restorative program and the maintenance program. So just to be clear, today we're discussing maintenance programs, not restorative programs. So our goal in the creation of these maintenance programs is to support our clients and their caregivers. We hold our clients in high regard, and often we want to work with them as long as possible. We can't be with the client 24 hours a day, and there comes a time when we need to train the caregivers to best support the client. So it's our responsibility to initiate this training early in the plan of care, and by initiating the training early, this will allow the caregivers to learn with us and grow with us as we learn more about the client and as the client becomes more and more independent as well. So many of you may be asking yourself, what is a maintenance program? And I think that's a valid question. I think there's a lot of myths about maintenance programs out there. So we're going to discuss the rationale behind creating a program, the Medicare regs, components of a maintenance program, how to provide caregiver training, and then of course how to document what we're doing so that we can obtain reimbursement. Now, maintenance programs are discussed in several areas in the Medicare Benefit Policy Manual, and the Medicare Administrative Contractors, our MACs, also discuss maintenance programs in their local coverage determinations. So each MAC's LCD is a little different. Therefore, for the purposes of our discussion, I'm going to discuss how the Medicare Benefit Policy Manual describes the maintenance programs. So this quote here describes the maintenance program process for a client who also needs skilled rehab. So I'm actually just going to cover the part that I have highlighted here. The goals of a maintenance program would be, for example, to maintain functional status or to prevent decline in function. The specialized skill, knowledge, and judgment of a therapist would be required, and services are covered to design or establish the plan, assure patient safety, train the patient, family members, and or unskilled personnel, and make infrequent but periodic reevaluations of the plan. And then it goes on to say that the services of a qualified professional are not necessary to carry out the maintenance program and are not reimbursable. Now, Medicare also discusses the creation of a maintenance program if actual rehab treatment is not indicated. So in this scenario, there might be just a very limited number of visits that are required during therapy, because our goal might just be to establish a maintenance program, train the patient or caregiver, and then discharge the person from skilled services. And basically it says evaluation and maintenance plan without rehab. If the treating qualified professional determines the potential for rehab is insignificant, an appropriate maintenance program may be established prior to discharge. Since the skills of a therapist are required for the development of the maintenance program and training the patient or caregivers, this service is covered. Now, our rationale in a nutshell: the goals of a maintenance program are to maintain the current level of function, maintain gains made during therapy, or prevent or minimize deterioration. So I think that it's only fair that if we are discussing the creation of a maintenance program, we would discuss the components of a maintenance program so that everyone feels competent with this skill. So first you need to establish some sort of a goal or goals for the program. And they can be very basic goals, and we'll talk more about goals. But goals are often related to maintaining the client's skills with ADLs, transfers, ambulation, etc. However, your goal can also be related to areas such as splinting or seating and positioning too. So it's often appropriate to train the caregivers on new care approaches as well, and be very specific about what works for that client. For example, you may be training the caregivers to do something that they regularly do with the client. However, now you're training them to complete the task with a different approach. I remember one time I was collaborating with a PT in my area, and we were discussing a particular client who exhibited aggressive behaviors during transfers and ambulation. And we see that time and time again sometimes in memory care units. And obviously this was causing a lot of difficulty for the care staff. So during the assessment, we decided that the client was functioning at an Allen Cognitive Level 2.4. And during therapy, the PT trialed a few different care approaches with the client to see if a different care approach yielded a different outcome. Initially, he just tried to change his communication style, so he was speaking in short sentences with her, and he was waiting for her to respond before he responded back. And he was layering on additional visual and tactile cues. And we kept trying these techniques, and none of these methods were successful. So we took a step back and we reflected on our experiences. And what we realized was that there was still a common issue that we could have an impact upon, and that was the environment. Because we weren't able to gain her attention, she was probably scared while the PT was attempting to transfer and walk with her. However, once we stepped back and we realized that we could have an impact on the environment and that the solution was fairly simple, we knew that we were going to be successful. So actually what we did was we trained the caregivers to eliminate distractions. So instead of transferring her from the dining room and walking to the living room first, we actually trained them to have everybody else exit the environment. For example, if they were trying to have the client walk from the dining room, from the common area to the dining room, they had everyone else transfer and walk to the dining room first. And then we transferred that woman last. And because the distractions were eliminated, we were then to gain her attention, and she was able to follow our commands and become very successful. So just something very small like that, we realized that we could make an impact on the environment, and we can make an impact on our outcomes as well. It's also important, so it's just train people on those types of care approaches. It's also important that we're including checkpoints in our maintenance programs. So, for example, maybe we would want the care staff to contact us if the client's not able to walk from their apartment to the dining room, and that was the goal. So if that happens, that they're not successful with that task anymore, then we would have those caregivers contact us. Or maybe our goal was for the client to complete their grooming with supervision. Once that caregiver needs to start providing more assistance, then they know to come to us. And the next thing that you want them to do is, after you've trained them, you want the caregivers or even the patient to return demonstrate that skill and even have them sign off once they've shown you that they're competent. And this last part of this slide is really very basic, but I think it's very important. It's important to keep copies of the maintenance program readily accessible to everyone. If the copies are in a binder in the therapy department, that information is never going to get out to the caregivers who need it the most. So make sure that even if you are keeping the information in the therapy chart, there's a common binder that anybody can access if you're, say, in a skilled nursing facility or a memory care unit or an assisted living. Now, as legacy therapists, we do have access to many different versions of maintenance program forms. So for example, the ADL program manual has one that is specific to ADLs and IADLs. And the seating and positioning manual has a form to use as well. You can create a home exercise program via the website that's on this screen. And if you have any questions about how to navigate that website to create a home exercise program, there's a WebEx that's on the intranet that you can check, that you can use to assist you. Now, we also have the opportunity to purchase maintenance program forms from a company called Dementia Care Specialists. They create forms that are specific to a variety of Allen cognitive levels. And each form includes care approaches that are specific to that level. So these forms are very nice. These forms are available by purchase only. So therefore, if you don't have them in your clinic but think they might be useful, contact your area rehab clinical specialist or your area rehab manager who can get you in touch with your clinical specialist in your area, and we can talk about getting those forms for you. Now, I do want to show some examples of maintenance program forms. So give me just a minute and I will set this up. Okay, this first form is one of those Dementia Care Specialist forms that I mentioned. It's very nice. At the very top, you can put the resident's name. You can put what discipline this is for. You can use it for 2 disciplines. You can just use it for 1 discipline if that discipline has 1 or more goals. There's a section to put the goals, and you'll want your goals to be more basic, and we'll talk more about that. Down below, what's nice is that there's a section for caregiver approaches. So I talked about once you figure out what works for a client, training those other caregivers to use that same approach. So sometimes these approaches are somewhat similar based off of different Allen levels. So this form, I believe, is a level 4 form. Yep, this is a low 4 form. So all of these caregiver approaches are ones that may be relevant to somebody that's a low 4. And then as we scroll down, there's any environmental modifications. And then as we go even further down, there's a section where caregivers can sign and indicate the date of their training. And then look at this. At the very bottom, there's that little checkpoint that I was talking about. It says caregivers. Please inform the therapist and or nurse if this program becomes ineffective. You might even highlight that so that it really sticks out to people. And I do realize that there's a lot of words and a lot of information on this maintenance program. So it may be helpful for you to even highlight the information that's specifically very helpful for that client. The back page is out. There's a back side too that's really nice. I'm not going to show that to you, but the back side's really nice, and it gives additional information for a therapist to reference as well. Now, I'm going to show you a version that's actually completed. Oh, whoops. Okay, so this is a program that somebody completed at a community, and it's a maintenance program for a person functioning at Allen Level Low 4. You can see the therapist put her name and the date at the top, and it's a PT, so she marks PT. And her goal was really basic. Resident will walk to and from dining room at least 2 meals per day with walker and supervision to decrease falls risk. And as we go down here, you can see the care approaches that she checkmarked. Do not proceed until you have gained attention and trust. Allow the client increased time to perform the activity, such as standing up and initiating walking. So that tips me off. That lets me know that this person needs extra time to process my instructions, and that's normal for her. And then as we go down a little bit further, you can see that the caregiver signed and dated the form. I'd also like to show another example. This is actually a wheelchair seating and positioning maintenance program. Now this one's much more detailed. Sorry, you're not looking at that right now. Okay, now you should be able to see the wheelchair positioning maintenance program. This is a little bit different of a function. This person has a specialized seating system, and sometimes caregivers get the different components of the seating system mixed up, or they forget which direction things go in, or what goes where on the chair, or even what components of a wheelchair belong on client A's wheelchair and what components go on client B's wheelchair, and so sometimes they can get those mixed up. So sometimes it's kind of nice to create a positioning maintenance program where you describe the chair itself, you describe the components of the chair, what are those extra features that that therapist added on, any helpful positioning tips. You can see here that the person needed assistance to maintain optimal positioning, and that the therapist was recommending that maybe check on the client every 1 to 2 hours to see if they need repositioned. And it looks like they just need a little bit of assistance, physical assistance, and maybe some verbal cues to reposition in the chair. Below here, they have some specialized cleaning and safety instructions. And I even like right here, or my cursor, it says when the cushion becomes flat or chambers become low, because this is a Rojo cushion, or if there's a question about the cushion, please notify the therapy department. So there we go. We've got the checkpoint. That might be a good thing to actually highlight. And you can see here below a section for caregiver training. And we've got some nice pictures of this client. You can see that she has these bolsters on the side of the wheelchair for positioning and comfort. And then as you scroll down, we've got a picture of what the chair looks like when it's completely assembled. And as we go a little bit lower, we've got a picture of that wheelchair cushion with the cover on and with the cover off. So those caregivers know what it's supposed to look like when it's functioning normally. Now, anytime you take a picture of a client, you are going to want to have a photo release, but sometimes it's just a really nice visual aid for those caregivers so that they really understand how the client should look. Just make sure that you're having them, that the client or the family is signing that photo release form. So let's talk a little bit more about what goals you can develop for a maintenance program. The main thing to keep in mind is that we often can't write our maintenance program goals the same way that we do our therapy goals on our therapy plan of care. Sometimes our therapy goals are to improve function. But remember, we're not going to be trying to improve function during the maintenance program. We're trying to maintain function. So we want to write our goals to be written so that we're maintaining function. Another area that I've noticed is that therapists often use abbreviations. And our caregivers might not be familiar with those abbreviations because they're very medically based. So for example, I recently encountered a very nice maintenance program goal. However, I'm not confident that the caregivers will understand the gist of the goal. And here's how the goal read. Ambulate distances up to 400 feet without AD plus SBA, arrow, CGA, and parentheses, HHA, +1 plus VCs dependent on LBP. That is a great goal. I understand the gist of that goal, and I know that basically that goal is saying ambulate distances up to 400 feet without an adaptive device or ambulation device, plus standby assist or contact guard assist or handheld assist, plus one person, plus verbal cues to be, and it's dependent on low back pain. So I know that that client's functioning better, a little bit higher, when she doesn't have low back pain. But when she has that back pain, she may function a little bit lower. But to a non-skilled professional or a caregiver or a layperson, that might not make sense. You've always got to write in layman terminology. Now, just basic ideas for goals in terms of OTs. We might want to write a goal for transfers, functional transfers, ADLs, self-seating, maybe participation in activities, splinting, seating and positioning setups. For PT, they may want to consider transfers, walking, exercise or range of motion, bed mobility places. And speech therapists are really going to focus on communication and swallowing as well. So as I was thinking about how to phrase goals, I was speaking with Ann Irwin, and we both agreed that simple is better. And if we can avoid medical terminology, that's going to probably help us. So a good basic PT goal might look something like this for a maintenance program. Resident will walk with handheld assist by one person for safety from the apartment to the dining room for all meals. Or an OT goal, maybe the OT's goal for the program is to have the person complete grooming. Resident will complete all grooming with supervision to maintain daily hygiene. Or for a speech pathologist, resident will consume meals safely. So once you get into you notice here I didn't include a lot of intervention techniques. The care approach is what I want the caregiver to use, or the methods for success. That can go in the meat and potatoes of the maintenance program. In the meat of the maintenance program, the therapist can describe the particular techniques that the therapist might want that caregiver to use. Like, for example, if the caregiver was being trained on a speech pathology maintenance program, particular techniques might be taking smaller bites, monitoring for pocketing, alternating bites with swallows of liquid, things of that nature. Now, successful implementation of maintenance programs begins with successful patient or caregiver training. Therefore, I want to talk about the methods that we can best use to support caregivers who are working so hard with our residents day in and day out. It's so important that the patient or caregivers buy into the program, because if they don't, our efforts might not be successful. So in order to establish buy-in, you should create the program in collaboration with the partners, with the care partners. Speak with them first, see what areas they're having the most difficulty with. For example, one of those areas, or actually one example of an unsuccessful maintenance program that I've encountered, was a maintenance program that a PT developed for stair climbing. So in some circumstances, it might be appropriate to indicate to caregivers that a client requires assistance with stairs. and how to teach that caregiver how to safely provide that assistance. However, the client for which this maintenance program was created lived on the main level of a memory care unit. So stair climbing was not a task that he needed to do on a regular basis, and therefore the activity did not have meaning and purpose for him, and it really just seemed like extra work for the caregivers. So not surprisingly, this maintenance program was not implemented by the caregivers after the client was discharged from therapy. It is also helpful to teach caregivers different care approaches. Instead of adding a task to their already busy day and asking them to do something extra, maybe you could teach them to do what they're already doing, but to do it differently in a way that you know will be safe and successful. It's also very important that we are assessing return demonstration of the patient and caregiver. We want to know that they're competent in the techniques that we're teaching them. It may be helpful to use the appropriate Allen level form if you like the dementia care specialist's maintenance programs. It is also going to be very helpful to, like I said earlier, include those general checkpoints on that form so that the caregiver knows that they can come to you if the client is either functioning higher than they were when you discharged them or functioning lower. But here's what I can't stress enough: the importance of being realistic. I remember one time I was working with one of the most skilled physical therapists that I have ever met. Very, very solid PT, had been in the profession for over 20 years. And she really cared about her clients so much. And I distinctly remember a maintenance program that she created in an assisted living community. Literally, this maintenance program was very extensive, and it wasn't successful because it consisted of 150 minutes of moderate physical activity per week. It also consisted of an exercise program, a walking program. She also had a positioning and hot back program to address the client's low back pain, and a work, rest, work activity interval so that the client would not become over fatigued during the day and that would not aggravate her back pain. So obviously those caregivers were very overwhelmed by that maintenance program. And they had a very difficult time carrying out that maintenance program. Now, I think it's also important for rehab directors and clinical program leads and all of us therapists that are training people on maintenance programs to really take a solid look at ourselves as well. So here are some things to keep in mind. Sometimes we may need to train the trainer. We may have a therapist in our department who is shy and doesn't really feel confident speaking to people and educating caregivers. So we may need to support that therapist. On the flip side, we may have a therapist that's particularly assertive, and some of those caregivers may bristle when they come across that therapist. So we really do need to take a look at ourselves and our training style. I think it's so important that we maintain a positive attitude as we go along with maintenance programs. And if a maintenance program isn't being implemented the way that we wish it was, then sometimes we have to keep that positive attitude and consider, is this really the maintenance program that I want to implement, or should I change the maintenance program to maybe something that's a little bit more realistic for the caregiver or has a little bit more meaning and purpose for the client. We need to talk to the key facility personnel and ask them what they think would be most helpful at their building or their community. Is one-on-one training with the care staff better, or small group training? If we need to hit a lot of caregivers at one time, is it better to do it at shift change? So those are definitely some discussions that we need to have with, like I said, the key facility personnel. I think simplicity is always so important. I think the more simple a maintenance program is, the more likely it is that it will be carried out. It's so important that there's return demonstration so that we know that everybody understands the maintenance program and is competent. And once again, like I've said over and over, those caregiver checkpoints. so that people can come back and talk to us if the maintenance program is no longer appropriate. So let's talk a little bit about documentation of maintenance programs. There are many areas in SMART that we can document a maintenance program or caregiver training. We can include in the evaluation that we want to provide caregiver training. We can include that in the assessment of our evaluation or in our discharge plan. We can include the information in our daily note. We can include it in our progress note or our updated plan of care. We can include it in, we really should be including it in the discharge summary as well. And keep in mind, anytime that you're discussing your maintenance program training or an educational topic, you'll want to include the client's or the patient's response to the training, return demonstration, maybe the need for additional training, or what degree they understood the program or the topic that you were training them on. As always for documentation, sometimes it's helpful to use the guidelines from your MAC or from the Medicare Benefit Policy Manual. Just a few phrases to get you started, to get you thinking about how you want to document. You could say something like skilled therapy services are needed now to maintain function. You could say improve a functional limitation, prevent or minimize deterioration. These are just kind of a jumping point for you. Now, in terms of coding, make sure that you're following the guidelines established by the MAC in your geographic region. Typically, you're going to want to code based off of what you did. So if you're ambulating the client and you're a physical therapist, you may document 97530, therapeutic activity. If you're training the person on a home exercise program, you may want to code that as 97110. Or if you're training the client or the caregiver on ADLs, you'll want to document that as 97535, ADL retraining. So next, Candy Rothenbuehler is going to speak, and she's going to talk a little bit more about reimbursement as well.
Well, when talking about a therapy maintenance program, it is very important to determine the components because it will help guide your reimbursement. And we saw on the previous slide that Medicare does pay for that establishment of that program. And the creation of it is considered a skilled service. And like Alyssa said, we follow the coding under which the program we have established. And that would be reimbursable by Medicare. So if you're doing self-care, you can bill under Medicare, under self-care, or private insurance. There are opportunities for us to do other skilled private pay for residents that maybe don't have Medicare, but their families are willing to do private pay options. And the billed code for that is 99003. That's billed at $1.30 per minute. If you have any additional questions on that, contact your ARM or your ARCs, and they can help guide that information and assigning that service. A non-skilled service is the actual implementation of a therapy maintenance program. It's non-skilled and therefore is not reimbursable by Medicare. This is the point at which you will discharge from Medicare services. That implementation piece will not be reimbursed. I want to stress that because that is not a skilled service. Legacy encourages us to create these programs utilizing the Medicare reimbursement rates and private insurance reimbursement rates and train the caregivers for follow-through. That is your best option. Your best option is to establish this program under Medicare reimbursement and train a caregiver for the follow-through. But if that is not an option, and it is absolutely necessary for you to follow through the implementation of that, Legacy does have an option. It's not a cost-effective program for your clinic, and I want you to be very careful to use that and only use that in the guidance of your ARM in your respective area. Another thing is that we want to remember is that if you're establishing a non-skilled or if you're implementing a non-skilled therapy maintenance program, your payer will be other. And it's billed under the codes 99001 and 99002. So that is reimbursed at $1 a minute. And again, I need to say that this is not a cost-effective program for your clinic. If you must use this program, do not use your PRN staff to implement this. It's not going to be cost-effective at all. These folks can be grouped together for their exercise programs. If you can see 2 of them at the same time, that will assist in the reimbursement. And I also want you to know that if you're going to be providing this, you have to be upfront with the family about the time commitment as far as minutes per day, the overall cost that you anticipate, and the length of stay. Try to be as specific as possible when you're talking with the residents so you're very upfront and they know what services that you're going to be providing to their family member. So if you're setting up this therapy maintenance program implementation in SMART, you must change the payer the day that the service is initiated. Some areas will create a separate person in there with TPM at the end of it, but you don't need to do that. If you change the payer as of the day the service is initiated, Tricia says that is sufficient for her. So the takeaway portion for you on this reimbursement is the best option for your clinic is to establish the therapy maintenance program under the Medicare reimbursement guidelines and then train the caregiver for the follow-through. If you must carry it out yourself, please contact your ARM or your ARCs and determine if that non-skilled implementation is absolutely necessary and something that you feel like needs to be followed through with Legacy. Alyssa?
Yes, thanks, Candy. That's a lot of really helpful information. So Candy and I want to thank everybody for joining us today. Together we can all help to enhance the lives of our residents. And at this time, I am going to unmute everyone so that we can address any questions that you may have. So give me just a moment. Okay, I have unmuted every phone line. Does anybody have any questions?
Hey, Alyssa, it's Kristen, and I missed if you told us where you find that dementia care specialist worksheet that you can give to caregivers.
Yes, you contact the clinical specialist. Together you guys can decide if that's an appropriate facility to use that form, and then the clinical specialist can place that order.
Gotcha. Thank you.
Through Ann Irwin. You're welcome.
Hey, Alyssa, this is Adrienne.
Hi, Adrienne.
How are you?
Good.
I just wanted to piggyback on what Candy was saying about the billing for the maintenance program, because in our skilled nursing facilities, obviously these codes are not an option for us because we use the billers in our skilled nursing facility departments. And so I just wanted to, if there are any rehab directors on the call that are in skilled nursing facilities in our division, to just reiterate what Candy said about being sure that we have this conversation about how you, if you feel like this is something that you would like to implement in your program, if there's maybe not a restorative program that's an option for you, or maybe it's a CCRC where you have an AL and IL that doesn't have a really strong fitness or wellness program. I do have some programs that run maintenance, structured maintenance programs where we use a tech actually to provide those services, but it is absolutely a conversation that we need to have with our customer before we jump in with both feet and do something like that. So I just wanted to kind of throw that caveat out there for any of those rehab directors who might be listening and thinking this is a great avenue for them. It may be, but it needs some conversation before we move forward.
Absolutely. With it being $1 a minute, we don't want any family members to get a bill that they're surprised about.
Mm-hmm. And to bill a code that the business office manager has no idea what it is.
Yes.
Thank you for that, Adrienne. This is Beverly. I'm on, and actually that was going through my head. So thank you for addressing that.
Okay, are there any other comments?
Can you hear me? This is Donna.
Yes.
Okay. I just have a question as far as the timing of implementing and designing a maintenance program. I've been in some settings in different states that have indicated that if you do this, like if you wait to like the last week or you try to extend care for however long you need, at the very end that it's not looked well upon by Medicare, that they feel like this should be something that's part of your daily program as you're seeing the person, as opposed to adding on additional week or two to establish a maintenance program. Do you have anything about that?
Yeah, I have seen some of those types of statements. Our best bet is to be training our caregivers early in the plan of care and keeping them involved very early on and knowing from the very beginning that we're going to implement or attempt to create a maintenance program as opposed to doing it at the very end just as a box that we're checking off prior to discharge, if that makes sense. So definitely consider maintenance program information training very early on in the plan of care.
Yeah, and then I think, you know, obviously at the very end they're going to be functioning differently than they were at the beginning, and it will take some training, but I think it's important to, you know, if according to what you're saying, then to be talking about it all throughout, you know, and be involved in it all throughout rather than coming up to the end of a plan of care period, for example, and saying that you want to extend it for another 2 to 3 weeks so you can establish a maintenance program. That
absolutely. Yep, those are all really good points. Does anybody else have any questions or comments or any experiences that they want to talk about? Okay, well, thank you so much for joining us today. This call is recorded, so if anybody needs the link at some point, just let your clinical specialist know and we can forward that link to you. So thank you very much and have a great week.
Thank you.
Thank you.
So we do 45 minutes of training.